Thank you, sir.
Yeah, I would request Uday now. Uday, please get the presentation.
Let's do it. All righty. So we're talking about a twist technique to explant a lens. You know, sometimes there is a need to take out our old IOL and replace it with a new lens. And there are many ways that have been described to do this. The traditional way is this, cutting an IOL inside the eye. And this works well, but it does require specialized instrumentation, such as these micro scissors and micro graspers. I know Ike was instrumental in getting this set out to the world, these MST style instruments. And once the IOL is cut in half or mostly in half, you can then pull out one half and then the other half will follow. And so this certainly works, but it requires, again, specialized instruments and it takes a little bit more effort. Also, you don't have the ability to have an intact IOL at the end. Once we get the IOL out of the eye, of course, the IOL has been damaged or cut in half, etc. So there has to be a better way. This is a technique that I learned from Jack Chapman in Georgia. I'm going to show you this. When I first saw him do this, I was blown away. It's to twist the lens within the eye. So all you need is a spatula and straight tying forceps. So there's the IOL on top of the iris. You grab the optic, not in the center, but at the edge. Grab the edge of the optic. And this video is a resident who is doing the entire case. Now the spatula goes on top. The spatula helps to roll the IOL. And so now we twist the tying forceps, trying to do a full 360 twist. Start with your hand either pronated and supinate or do the opposite. And then once it's rolled about 360 or as much as you can, just pull it right out of the eye. And so now you can explant that single piece acrylic lens through a 2.75 millimeter incision. Here's that same case outside the eye view. So you can see twisting it and it just comes right out the incision. So it works very well. Again, spatula is important to hold the lens and help roll it, plus protect the corneal endothelium. Anterior chamber is filled with viscoelastic. Once we get the lens twisted, again, we pull it right out of the eye. So it's a very useful technique that I think in your surgeries, you'll find to be a benefit. Here's now with a curved tying forceps. You see it's a little bit more awkward because the forceps aren't straight. The tips are straight, but there's a bend in the shaft. But still, even this video from a resident many years ago, you can see we can still pull the lens right out of the eye. Now the lens is intact, and we can measure it or examine it or whatever else you need to do for that. And so here we go. One last time, remember, grab the optic not in the center, grab it in the periphery, the edge. One haptic's already outside the eye. Spatula going on top. We're gonna slowly twist the forceps. And again, to get the full range, go in, for me, supinate, and then go in and pronate. And you'll get almost 360 degrees, which is enough. Now we can roll it up. We've tried this with the Alcon Acrosoft lenses. AMO Technis lenses have worked well. We've even explanted a 3-piece acrylic lens with no issue at all. If you have a silicone lens, keep in mind the silicone lens is very slippery, and that's a much tougher one. So we recommend this technique for acrylic IOLs of 1-piece and 3-piece varieties. And again, you want to take the lens out, put it on the cornea afterwards, just to make sure you haven't broken off a bit of the lens, the haptic, etc. So in that case, after we explanted that one lens, I'm just going to show you for the new lens, this patient is getting a 3-piece lens. As that lens goes, it's going to be placed in the sulcus. It's first placed on top of the iris, and then it can be dialed into position. So if you have a patient with a need for an explanting of an IOL, I encourage you to try this technique. You'll be quite impressed that it works so well. And then, Arup, we're ready for any questions, and then others we can move to the second talk.
I think we'll just take up some questions. Madhu, you had any questions to be posed to Dr. Uday? Any comments to make?
Yes, sir. Very nice presentation, sir. I have a few questions that what is the exact position where we have to hold the IOL, and whether you have enlarged the incision and how much you have enlarged.
So I think a 2.75 incision will work fine. You don't have to enlarge more than that. If you did Phaco through a small 2 millimeter, 2.2 incision, you probably should enlarge it to 2.75, 2.8. You want to grab at the edge of the optic, right where a haptic is. So you saw in the video here, we pull one haptic outside the eye and then grabbing the optic at the edge. That allows us to roll it up. And Madhu, I used to do left-handed as well, but when I was a kid, my parents made me switch to right. So now when I do Phaco, I can do it either way, it doesn't matter.
Yes, sir. And one more question, sir. Any effect on endothelial cell count in this technique?
So we only had one patient where we did an endothelial cell count before and after, and we found no appreciable difference. It was within 1% or 2. So we're very careful to stay away from the cornea. That's the purpose of the spatula. Plus, you're doing this under the protection of viscoelastic.